We're very fortunate today to have Dr. Brett Kuhn, who is a nationally recognized expert in childhood behavioral sleep problems. And Brett, I was going to ask if you'd be so kind as to start off by telling us something about yourself. What is your role here at Monroe-Meyer Institute at the University of Nebraska, Brett?
Okay, my name is Brett Kuhn. I'm a licensed psychologist. I specialize in pediatric psychology with an even further specialization in pediatric sleep. I'm an associate professor of pediatrics at the Monroe-Meyer Institute and University of Nebraska Medical Center.
Brett, could you please give us an orientation to behavioral sleep problems for children? In particular, could you talk about their prevalence and why they are of major concern to children and their parents?
Well, there are a variety of sleep problems or sleep disorders in children, anything from obstructive sleep apnea, which we may see in kids with certain craniofacial abnormalities, to parasomnias, and then circadian rhythm disorders, problems with the sleep-wake regulation, and then finally behaviorally based sleep disorders where children often engage in disruptive behaviors in order to avoid bedtime, or may awaken frequently. And what that leads to is they oftentimes don't get enough sleep, and of course when children don't get enough sleep, their parents don't get enough sleep.
That must be a major source of stress for a number of families, in particular when the child's sleep problems disrupt the family routine and create a source of stress for the parents who might not themselves be getting enough sleep.
It is a major source of stress for families. I've yet to have a 3-year-old child come into me in my clinic saying, "Doc, you got to help me, I can't sleep," but yet their parents drag them in each and every day. So again, when kids don't sleep well, parents don't sleep well, and it just ends up sometimes being an explosive situation.
Is this an area that's unique or overrepresented in children with disabilities or on the autism spectrum? Or is it something that seems to cut across the board for nearly all children, regardless of diagnosis or neurotypical neurological development?
Studies throughout the decades and across different countries reliably find that 25% of young children and 15% of older children, adolescents, have one diagnosable sleep disorder, at least one diagnosable sleep disorder. When you get into children with developmental disabilities, genetic syndrome, handicapping conditions, you can at least double that rate. We don't know exactly why. Obviously, there are physical limitations on occasion, but in my mind, in my estimation, sometimes parents just have so much on their plate when they have a special needs child. They're dealing with the medical issues, they're dealing with the behavioral issues, they're dealing with academic and learning issues. Sometimes it just takes a while to get around to targeting their sleep problems.
Okay, great. When somebody comes into your clinic complaining about sleep problems for their children, what sort of assessments do you typically do? What types of questions or instruments do you typically do that help inform you about the problem and the types of treatments you might pursue?
The first thing we want to do is rule out physiological problems related to sleep. So clearly we want to make sure that the child is breathing okay at night and isn't snoring, doesn't have obstructive sleep apnea, doesn't have symptoms of narcolepsy. Those are more rare disorders. Children with behaviorally based sleep disorders, we don't have an objective laboratory study. It just doesn't capture the type of information that we need to get. So a lot of it is a well-designed, structured or semi-structured clinical interview from a functional frame of mind to identify all of those variables that are impairing a child's ability to sleep appropriately.
Brett, it sounds like one of your first steps is to try to rule out some of the physiological causes for sleep problems, perhaps by referral to a pulmonologist. And then after you've ruled those out, it sounds like you might then start pursuing questions about behavioral factors that might contribute to sleep problems. Is that correct?
Exactly. So the majority of the clinical interview is designed to elicit those behavioral factors that impair and impede sleep in children. We oftentimes just open things up to have parents describe the reason they came in. Once they're done telling their story, we try to identify past treatment attempts. And again, here's where the ability to conceptualize from a behavioral standpoint, it can be very helpful to identify why past treatment attempts didn't work for this individual child and make sure that you don't go down that road again, that your treatment plan addresses those loopholes or those gaps, those problems. The next thing we'll look at is parent-defined treatment goals. So I have my goals for my children and how I want them to sleep, but that may not be why this particular parent is in the room with their child. So we want individualized, behaviorally specific, measurable treatment goals so that we can head true north the entire time and make progress.
On a naive level, it sounds like the goals might be pretty standard across individuals, but I get the feeling from what you're saying, Brett, that there might be some cultural or familial variability in terms of what their goals might happen to be for their children and their sleep. Is that correct?
That's one of the reasons we want to make sure that parents identify their own individual treatment goals, because there are differences in sleep practices across cultures, even within the metro area here. There are differences in parent desires and wishes in terms of how and where and when they want their child to sleep. So we want to make sure that they're able to identify their treatment goals, and we're working with them to meet those treatment goals. A good example is the sleep program that I'm going to describe here in a bit is really more tailored to parents who desire to teach their child to become an independent solitary sleeper. It's probably not as valuable for those parents who desire to co-sleep or bed share all night, every night as a routine practice.
Brett, it also sounds like you ask your clients about prior treatment experiences and successes. Can you help us understand, perhaps with an example, Brett, what information you're looking for and how that might inform either your assessment or your treatment strategies?
Well, one of the most difficult cases coming in our sleep clinic door is those children who have been already through a, quote, cry it out or extinction-based procedure and who become very tolerant or have trained persistence to where they've cried for long periods of time. And then the parents, for whatever reasons, and sometimes understandable reasons, terminate the protocol, go in and provide the reinforcement. So for those children, if we simply said, okay, let's go straight to a cry it out or extinction-based program, we're going to be 2 or 3 hours into the protocol before the child recognizes a contrast in the programming.
Could you describe in a little more detail for the practitioners the critical elements of an extinction-based protocol such as the cry it out procedure, and in particular comment on the strengths and limitations of that particular procedure?
Well, if you look at the empirical literature, the large majority of the research has been done on single techniques, and most of them involving extinction. Or extinction modifications, extinction variants. So straight extinction. Now, when I say extinction in the sleep literature, I'm talking about ignoring, okay? Because we don't have in the literature yet a formal way to conduct a functional analysis of behaviorally based sleep problems. So we haven't specifically or scientifically identified those controlling variables. So when I refer to extinction here, I primarily mean ignoring. But obviously extinction is difficult for parents oftentimes to execute. If they're not warned ahead of time, they may see that post-extinction response burst, the extinction burst. They may end up caving in and reinforcing more unique or severe occurrences of behavior. And now you as a clinician have to be able to deal with that and solve that with your treatment plan. Extinction-based protocols are poorly viewed by a lot of parents. And if you don't believe me, go in and search on the internet, cry it out for sleep problems. And it's rare for a family to come into my clinic who haven't already tried some variation of an extinction-based protocol. Finally, extinction does a very nice job and is very effective and expedient at reducing problem behaviors. But it does nothing to teach, train, shape, or reinforce replacement behaviors, which I think are critical in teaching especially young children to fall asleep independently and maintain sleep throughout the night.
Just for clarification, could you describe the procedural elements of the cry it out routine? In particular, I'm assuming that you're thinking that the parent attention, such as coming into the room when the child is crying, is construed as the reinforcer, and now you're trying to arrange extinction with respect to that source of reinforcement.
Yes, so the original unmodified extinction protocol calls for parents to place the child in bed, turn the lights off, and walk out and not return until the next morning unless there's a sense that the child may be in danger. That is a very effective, a very expedient treatment protocol. Parents, again, tend not to like that approach, so people and professionals have come up with variants, and primarily checking procedures. The classic being, 1985, Dick Ferber came out with graduated extinction, where the parent walks out, ignores, and then walks back in the room to check on the child at 5 minutes, then at 10 minutes, and then at 15 minutes. And of course, if you conceptualize behaviorally, you worry about, again, teaching the child to persist longer and longer and longer if the reinforcement value is there when the parent enters the room. So when I work with parents on a graduate extinction protocol, we talk a lot about minimizing the reinforcement value when they walk in that room for those checks. Behavioral analysts will recognize this as a time-based reinforcement program or some type of non-contingent reinforcement.
Just for clarification, Brett, could you describe in a little more detail the graduated extinction procedure? It sounds like they're going in every 5 minutes, then eventually every 10 minutes. Part of the concern might be, is there a potential that by going in, and if you go in at the time the child is crying, that you might accidentally reinforce crying and other potentially inappropriate behavior on the part of the child? So I guess what I'm asking is, do you have any sort of exclusionary criteria about when you might go in or not go in on the graduated extinction procedure?
Traditionally, the graduate extinction protocol increases the checking interval within a single night. There are variations on that, of course. There are variations on all these extinction-based protocols. But certainly there is the risk with when parents don't fully understand the procedure and the purposes, that they end up going in contingent upon child behavior as opposed to passage of time. So they could intermittently or inadvertently reinforce, again, more severe, creative, unique forms of crying, screaming, shrieking, which then is, again, hard to extinguish later on.
And Brett, just for clarification, is the advice for parents to go in and have minimal interaction with the child when you go in to check, or is there programmed interaction that might be of a reinforcing nature between the parent and the child?
I told parents that those checks are really for them, not for the child, because honestly, when they walk in the room during the time-based check, the child looks at them and thinks, I'm saved. You're here to save me. You're here to put me back to sleep. So when the parent goes in, minimizes the reinforcement value by just checking on the child, maybe talking to them for briefly, and then when they turn around, the children don't take very lightly to that. They don't like that, and oftentimes it just ends up fueling more crying. It ends up taking longer for them to finally settle and fall asleep. So you could also do an extinction modification by simply watching the child on today's modern low light sensitive video cameras to make sure that the child's safe, hasn't vomited or spit up, hasn't accidentally woven their legs between the crib rails or anything like that. So
it sounds like that's a fairly important component in a treatment protocol, Brett. Is that where you would typically start, or are there other components that are worthy of consideration and other assessment considerations, Brett?
Almost all of the pediatric research thus far, the behavioral pediatric research thus far, has looked at the efficacy of isolated techniques. And again, most of them are extinction-based or modifications of extinction. To my knowledge at this point, we haven't looked at the efficacy of a multi-component treatment program or manual. However, if you look at clinical practice guidelines and experts' review articles, they all include some fairly similar components.
Could you talk a little more about other components, perhaps above and beyond extinction-based interventions, that might be built into a behaviorally based intervention program for sleep problems in children?
So just to emphasize, with most behavioral sleep problems, it is the contingency management piece or the parent-child interaction piece that is the key active ingredient, okay? But over time and with experience, we have just found that there are other components that you can add to enhance the parent-child interaction or contingency management piece. One is simply monitoring, assessing, and maintaining an appropriate sleep-wake schedule. So one of the things that happens is parents think, well, geez, if it takes my child an hour to fall asleep, and he's not falling asleep until 9 o'clock, if I just put him in bed at 7, he'll be asleep by 8, and then we can go and watch TV or read the paper. Unfortunately, sleep physiology, specifically our circadian rhythm, just doesn't work that way. So oftentimes we go just the opposite direction, and we try to make sleep itself more reinforcing by either temporarily delaying the bedtime, okay, to take advantage of this child's circadian rhythm and increasing homeostatic sleep drive, or sometimes we may use a minor sleep restriction therapy leading up to the contingency management procedure to make things go more smoothly.
So it sounds like a major component of a comprehensive behavioral sleep program is to put your children to bed when they're drowsy, but don't let them fall asleep out in the living room, but actually they go into the bedroom when they are indeed drowsy.
That is a key component, especially for younger children, and that putting children into their habitual sleep environment, drowsy but awake, to allow them the opportunity to initiate sleep in the place and under the same cues that they're expected to maintain sleep is a key component. Easier said than done, but those children, in the sleep literature, we call that sleep onset association disorder, where they are dependent upon parent-delivered cues to initiate sleep. And it's very common to have a child come in who is put to sleep through rocking, feeding, singing, even dancing in another room. And then once the child's asleep, they transfer that child into their bedroom or their crib, their own crib. And then of course, the child completes their first sleep cycle, has a brief arousal, which is perfectly normal, but instead of looking around and realizing, yeah, I've been here, done this, going back to sleep, they have difficulties. They've got to cry out or come out of the room to recontact those familiar cues or discriminative stimuli.
So it sounds like an important component is to establish a sleep routine, a bedtime routine that is not completely dependent upon what you might call parent-initiated cues such as singing or rocking, but involves putting the child in bed essentially.
For younger children and some children with developmental disabilities, they really do have a skill deficit and are unable or have great difficulty initiating sleep without parent assistance, presence, or help. So that's a difficult road ahead, but the excuse me drill that I'll describe in a little bit is uniquely designed to target independent sleep initiation. And we usually start at bedtime, and then once the child has 7 to 10 nights of success initiating sleep independently at bedtime, then we'll generalize the program, the treatment program, to other sleep opportunities like middle of night awakenings to allow them to fall back to sleep after completing a sleep cycle. And finally, we'll target naps if those are appropriate given the child's age and stage of development.
Brett, it sounds like an important component of a package involves the parent-child interaction, in particular the contingencies that the parent brings to bear. But before you get to that stage, are there some other considerations and other treatment components that you might want to consider?
Indeed, the key component is the contingency management piece and modifying or optimizing parent-child interactions. But there are a lot of steps that clinicians can take to prepare the parent and the child for that step, that difficult step. The first is making sure that you have established a sleep-compatible environment or bedroom environment in our culture. And that, we know that human beings initiate sleep and maintain sleep better in a reasonably dark environment, in a place that's quiet, although white noise is actually good, cool and comfortable, and in an environment that is perceived as safe, so that children can let down vigilance, relax, and fall asleep. The second step is to make sure that once you've created that environment, you have to actually insist that the child falls asleep there. So I've supervised students who quickly establish that this child is falling asleep in a dark, quiet, pristine environment with the canopy bed and the 400 thread count sheets. Okay, great sleep environment, but unfortunately that child was falling asleep on the mom's lap in the living room. That doesn't do us much good. So one of the critical first steps is to make sure that we're not using, for example, an extinction-based intervention by putting the child in a foreign land and not first establishing discriminative stimuli or sleep cues to allow those replacement behaviors to occur. So we may simply, at the end of our first appointment, recommend that parents insist or require that child to initiate sleep in their habitual sleep environment during every sleep opportunity. So initially, we may allow them to help the child fall asleep in that environment. They may stay in the room with the child. I tell parents, if you've got a special dance or song that works, that's great. We'll blend those stimuli initially and get the child comfortable, accustomed, and confident falling asleep in that habitual sleep environment, and then we can do the parenectomy later.
Parenectomy, that's a good word, and it's a very apt description of what might actually have to happen, Brett.
You know, the bedtime routine, although it has been shown in one study to help, it's probably overrated, to be honest with you. I think it's important to have a regular bedtime routine that sets the stage for sleep onset. The parents who come in to see me in my clinic, most of them have established a regular routine. So I typically don't focus on that per se. If you really want to set the stage for quick sleep onset, morning wake time, a consistent morning wake time combined with bright light exposure actually sets our physiology so that we're prepared for sleep at the same time every night.
So establishing a consistent sleep-wake cycle seems like it's a very important component of kind of an overall comprehensive sleep program.
It is. In fact, one contraindication to starting a contingency management procedure at bedtime is a family who has a chaotic lifestyle, who may have a very inconsistent sleep-wake schedule, who are placing a child in bed when they're simply physiologically not prepared to sleep, or in some cases a parent who's just simply overwhelmed, and they may place the child in bed more for respite than based on the time needed to allow that child to get enough sleep.
It sounds like some sort of a consistent routine is fairly important, Brett, but I can also imagine a number of families having pretty inconsistent sleep arrangements from week to week or day to day even, with sometimes the child sleeping at the mother's house, sometimes at the father's house, sometimes with the babysitter. So those sound like they might be interesting challenges from a behavioral sleep perspective.
That can definitely be a problem. So we want to, before the child, again, before we establish the contingency management procedure and pull parents out of those pre-sleep cues, we want to make sure that the child has those replacement skills. And one of those is making sure that they're actually sleepy, prepared to sleep when they're placed in bed. One other little tip is carefully choosing who is going to implement the treatment protocol. So oftentimes in your clinical interview, you can identify different parenting styles. And there may be differences also in the child's behavior and the level of disruptive sleep-related behaviors with one parent versus the other. You know, when you go to a contingency management program and you alter parent-child interactions, that can be tough on children, okay, and it can be tough on some parents. So you want to be careful in choosing who's delivering that intervention. Oftentimes, when you're withdrawing reinforcement, you're better off selecting the parent initially who can tolerate some child distress, who doesn't get anxious, or who will follow through with the program initially. Once you have success and the child is developing new, more adaptive sleep onset skills, we can blend the other parent back in to where they're both implementing the program, and then gradually fade out the first parent so that both parents are adept at delivering the protocol independently.
The parents sound like they're important components of this, Brett. In order to make this work with the parents, can you typically simply instruct the parents or give them a written protocol? Or do you oftentimes have to make trips to the home to provide some sort of coaching and direction and maybe even modeling for the parents?
Ideally, I would love to go to every child's home and observe parent-child interactions at bedtime. Practically, it's just not feasible with a busy clinic schedule. So videotapes, okay, videotaped observations are a great way. If you can't get the information through a semi-structured clinical interview, a lot of times with today's camera phones and very inexpensive video recorders, you can observe parent-child interactions at bedtime, which will give you a lot more specific and important information than simply getting it through a verbal interview.
If you do have the wherewithal to get a video recording of a bedtime routine and it comes back to your clinic, what do you look for in those video recordings?
When I'm observing parent-child interactions at bedtime, I'm looking for contingency management problems. So in other words, I'm looking for a parent who is adept and able to identify appropriate pre-sleep behaviors and who reinforce those, and those who also don't end up inadvertently reinforcing intermittently problem behaviors like coming out of the room with food, attention, 5 minutes extra TV, or who enter the room, okay, contingent upon problem behaviors, or sometimes in the case of creative children, various things that they come up with to drag the parent into the room. So it's interesting how young children oftentimes are not interested in having a conversation with a parent, but as soon as they're placed in their bedroom, they want to know the meaning of life or why the sky's blue, or oftentimes, and again, they're being placed in an environment, an appropriate sleep environment is relatively devoid of reinforcement. So oftentimes young children who aren't accustomed to that or don't tolerate that well will generate behaviors to increase reinforcement value and drag that parent in, to bring their 15th glass of water, to request that water have added ice from the refrigerator, cubed, not crushed, shaken, not stirred. Most parents, after going in there for the 20th time, finally realize that maybe it's not that my child's so thirsty, maybe it's me that they want.
That sounds like a familiar routine for many parents. I'm wondering also about other sources of reinforcement beyond the parents. Do you have any advice for parents about the presence of like video games or television or other forms of reinforcement in the sleep environment, Brett?
Yeah, absolutely. One of the first steps we try to help parents accomplish is, again, establishing that sleep-compatible environment. And sources of light, especially screens that have the blue phase of light, have an alerting effect. And there's study after study documents that children who have television in their bedroom do not get as much sleep as those who don't. So we've got to eliminate screen time. We've got to eliminate probably their top 3 or 4 more stimulating or fun toys, enjoyable toys. Again, a sleep-compatible environment is relatively devoid of stimulation. So that's why I think it's important to teach parents and prompt parents to go in the room every once in a while and deliver some social reinforcement and praise, maybe even some touch for children who are playing by the rules.
Brett, we've already covered now something about how you establish a sleep-conducive environment, establish some sort of a sleep-enhancing routine, and maybe even make sure that there's kind of a, I think you call it a homeostatic drive to fall asleep by having some level of sleep deprivation or drowsiness. Can we now talk a little bit about the other side of the coin, so to speak? What sort of contingency management strategies might a parent bring to bear for a child that protests going to bed, that cries in bed, that gets out of bed frequently at night? Help us a little bit with the contingency management side that you would be recommending for parents.
So the first step you've got to accomplish is making sure that parents understand the ultimate goal. Okay, for some children, the ultimate goal at the end of the night is, no matter what you went through, is did they independently initiate sleep without the parent in the room or without parental assistance. For other, maybe older children who may have more skills and aren't completely reliant on parental presence or assistance, the goal may simply be to reduce the occurrence of disruptive bedtime behaviors, frequent nighttime awakenings, or any behaviors that may interfere with the process of sleep initiation. So we need to make sure that parents have their eye on the prize and that they know what, in the end, a successful night looks like. After that, we're really looking at modifying or optimizing parent-child interactions to help children learn critical pre-sleep skills. What behaviors end up getting positive attention, what behaviors end up being extinguished or aren't going to get any parental attention. So again, the large majority of the research has been on extinction and its variants, but we have other protocols also that rely a little bit more on reinforcement, shaping, etc.
You mentioned procedures that rely on reinforcement and shaping, I would certainly imagine that those are more palatable and easier to get parent compliance than treatment protocols that rely mainly on extinction. Could you talk about some of those reinforcement and shaping routines?
Yeah, we don't have any actual formal research studies on treatment acceptability, but there's consistent research in the daytime behavior literature that parents tend to prefer procedures to increase appropriate behaviors rather than behavioral reductive procedures like extinction. So one example is bedtime fading with response cost, which is a very well-established protocol for kids, has been used more in institutionalized settings with children with special needs. It relies much more heavily on increasing the value of sleep over time and less on reducing problem behaviors. So if you want to think of it as a concurrent reinforcement schedule, basically over time you are increasing the reinforcement value of sleep itself.
Can you describe that procedure in a little more detail?
Bedtime fading with response cost, again, what we're going to do is temporarily delay the bedtime. That's been done in different increments. I know in my clinic, when I do a bedtime fading component, I look at the pre-treatment or baseline sleep diary and forget about what the child's bedtime is and actually look at their consistent sleep initiation time. So if bedtime's at 8, but they're usually falling asleep around 9, I'll move temporarily the bedtime to 9 o'clock. Again, circadian rhythm, increased homeostatic sleep drive. The response cost piece of that protocol is if the child doesn't fall asleep within 15, 20, 30 minutes, depending on the study and the protocol, you actually remove the child from bed. And at that point, there's no real firm instructions on what they're allowed to do. You're not trying to manipulate or control their behavior or manage their behavior. You're not trying to minimize reinforcements. I believe you should minimize light exposure, but at that point you're basically waiting for, again, the child to become sleepy before returning them to bed and allowing, hopefully more quick sleep initiation. What's interesting to me is that, when you read the pediatric sleep literature and you look at bedtime fading with response cost, if you read the adult insomnia literature, that protocol is almost identical to a combination of protocols that we use for adult insomnia called sleep restriction therapy and stimulus control therapy.
We just call them different things?
Just call them different things. It's pretty much the same, very similar.
Okay. Does that procedure tend to be pretty effective for children?
It does. We have fewer research studies on bedtime fading with response cost, or a few in the works. But it's been shown, at least in institutionalized settings, to be very effective with kids who have special needs.
You mentioned some other procedures, including the bedtime pass. Could you describe that procedure in a little bit of detail and how it might actually be used?
The bedtime pass is especially suited for older, more skilled children who have the ability to fall asleep independently, but maybe they continually creep out of the room in order to access parental attention. They want that extra hug, they want that extra kiss. The bedtime pass is simply a laminated, or it could be a piece of wood for all that matters, placed underneath the child's pillow, and it allows the child one permitted exit from the bedroom to gain access to something that they may want or desire. They surrender that bedtime pass at that point, and once they return to the bedroom, we continue an extinction-based protocol. So a little tweak to that is if you want to add a reinforcement component, you can actually give them access to a grab bag or prize bag or stickers the next morning if they choose to keep that pass all night and not utilize it.
So the bedtime pass sounds like it's the proverbial get out of jail free pass, at least one time. Once the child has used that pass up, what happens if they get out of bed again? What do you instruct the parents to do if they've used their pass and they still continue to get out of bed?
If they leave the bedroom and they don't have their pass left, the goal is to basically get them back into the bed by minimizing attention. So they're not allowed any conversation. You might even minimize eye contact, simply get the child back into the bedroom and ignore any further attempts or bids for attention.
And it sounds like the bedtime pass has a nice reinforcement component, so that if you haven't used your bedtime pass by getting out of bed the previous night, when you wake up in the morning, you can cash it in for some sort of valued item or activity. Is that what I'm understanding?
Yeah, exactly. You can turn that bedtime pass into some, some tangible prize the next morning. So parents tend to like that tweak.
You made a distinction, if I heard it correctly, Brett, between can't do and won't do. It's almost sounds like there's some situations where the child has the skills but won't engage in the right skills, almost a motivational problem. And then maybe other situations where the child has not yet developed some of the sleep onset skills, kind of a can't do. Is that a valuable distinction, Brett?
Oftentimes for infants and toddlers, they just haven't developed either the breadth of sleep cues to allow them to initiate sleep in a variety of circumstances, or they just haven't developed the critical sleep onset and maintenance skills. So in those cases, we tend to go slow. We tend to work more on building skills before we pull away their dependent sleep cues that involve, again, parental presence or assistance. So we may reinforce more heavily, put them on a thicker reinforcement schedule, and again, build skills before we remove the problematic sleep cues.
And then it sounds like on the won't do side
And
of
the
it,
won't do,
you
if
really
we've got a
work on
kid that's,
motivation, yeah.
they've got the skills and it's really a performance deficit, then we really have to tightly manage parent-child interactions and make sure that our contingency management program is pristine.
And that's an interesting distinction, at least from my perspective, from so many behavior problems for children, can't do versus won't do. And can't do oftentimes requires skill acquisition and training, and won't do seems like it's oftentimes a motivational issue. And the critical issue is, how do you motivate the child to do what they can do but won't do?
I mean, realistically, I'm a little bit of a foreigner when I go to the pediatric sleep meetings, because oftentimes my treatment protocols and my interventions for bedtime and in the middle of the night are based on what we've already shown to be effective to reduce problem behavior and increase more appropriate behaviors during the day. And we've been using these methods for decades.
Brett, what other sort of techniques above and beyond what we've talked about already might a clinician or a parent need to know about to handle some of the sleep problems for children?
Well, about 15 years ago, after struggling mightily to get parents to adhere and implement extinction-based protocols appropriately, I decided to tweak the intervention a little bit. One of the big problems with extinction is that it doesn't teach the child replacement skills or behaviors. I've yet to successfully help a parent toilet train their child, for example, by simply ignoring what you don't want them to do. So I had the idea, and I've lovingly called this the excuse me drill for a couple of decades now, to actually have parents go in and reinforce sleep-compatible behaviors. You could use stickers, you could use trinkets, you could use a lot of things. But with most of these behaviorally based sleep disorders, we've already established that parental presence and parental attention is sufficient and salient enough to reinforce problem behavior. Why not just reverse the contingency? Why not just take what we already know is a salient reinforcer of the child and deliver that based on sleep-compatible behaviors, specifically when the child lies in bed, remains in bed, reclining position, relaxed and quiet. And we can start this reinforcement schedule on a very thick, frequent basis. So we have parents going in there. Sometimes they don't even get out of the room. They literally say, excuse me, but I need to go tell your dad something or tell your mom something. They may not even get out of the threshold of the door, and they're back immediately to touch, praise the child for being brave, for being a big boy, for remaining in their bed. And over time, on an intermittent basis, okay, we're thinking long-term maintenance here, on an intermittent basis, they continue to go back in the room, but they fade the frequency or the reinforcement schedule, basically.
Brett, that sounds like a very effective intervention component for a multi-component sleep protocol. Can you talk in particular about the clinical response to these treatment protocols? In particular, how effective are they? How quick do we get a response to them? And do we sometimes end up with treatment non-responders and treatment failures? And what do we do about those, Brett?
As long as you kind of pave the way and establish those appropriate sleep environments and make sure that you've got an appropriate sleep-wake schedule, your contingency management program to teach the child appropriate pre-sleep skills and to get them to fall asleep more quickly oftentimes occurs within the first 3 to 4 nights of intervention. It can be very quick. That's why I'm in this business. It's very reinforcing to work with young children who have behaviorally based sleep problems. So it's not unusual to see dramatic success within the first 3 or 4 nights. Now, we may have success with certain outcomes and then need to later on target other behaviors or problems or outcomes. But initially, we want independent sleep initiation to occur the very first night. If it doesn't, as clinicians, we want to know that the very next day and problem solve that. Okay. Once we've chalked up, 4 to 7 successful nights of initiating sleep at bedtime successfully and independently, now we're going to generalize that to middle of night awakenings. So the entire protocol, because we tend to go slow and identify specific target behaviors and specific sleep opportunities to help parents have success, the overall program may take quite a while. It may take weeks, but you should see child response and you should see improvement with each step of the way within a matter of 2 or 3 nights.
It sounds like a relatively quick response to these treatment protocols, Brett. That's wonderful and must be a fantastic relief to parents once they started implementing them. Now, you also mentioned something, though, about middle of the night awakenings. What advice do you have for parents about managing middle of the night awakenings and efforts to get out of bed?
If parents choose to target bedtime only with their contingency management program because they've got 5 children and it's a dual career family and they can't be awake all night managing a sleep problem, we can target bedtime only and later on hit the middle of the night awakenings. While we're targeting bedtime only, my recommendation is typically in the middle of the night when the child wakes up normally, calls out, comes out, respond to that immediately and do what they normally do. So go ahead and just give the child whatever they're expecting, whatever they need to facilitate sleep reinitiation. That way, once we do generalize an extinction-based protocol or change a contingency management procedure in the middle of night awakenings, the contrast is there, the child recognizes it right away, and we get quicker response.
Great, sounds good.
The reason we tend to target bedtime first is just simply because we've got the greatest homeostatic sleep drive. So children, because of brain development and the way their sleep-wake schedules work, they oftentimes profit handsomely from a 4-hour power nap in the middle of the night, and it's more difficult to change things in the middle of the night than it would be at bedtime. Nap times are our final target, because it just tends to be more difficult. So we want things going pretty smoothly. We want the child to be very skilled. We want the parent to be very skilled once we finally go in and target nap times.
Brett, you mentioned nap time. Many children, by the way, are in daycares where there is a scheduled nap time behavior. Can you offer any advice as to how to promote appropriate sleep behavior at nap time?
The biggest issue I see with nap times, first of all, is parents who want to eliminate or restrict naps because the child's not going to bed well at night or has disruptive behaviors. They're thinking that the child's just simply not sleepy at night, when in reality they're engaging in all kinds of disruptive behaviors that just simply interfere with that sleep initiation. So most children under 4 years of age really need a short period of daytime sleep. If they don't get that, you're likely to see problems with mood, sometimes even behavior, aggression, attention span in the later afternoon. So I oftentimes work with parents to reinstitute naps for those poor kids who aren't getting them, because it's not an effective treatment for disruptive bedtime behaviors. In daycares, what I oftentimes see, first of all, is many of them hire people to come in and pat backs in order to put the child to sleep or in order to calm a child during nap time. And of course, they're not trained in behavioral methods and they don't understand contingency management, so they end up, of course, patting those backs of the children who wiggle the most. So oftentimes it's just a matter of changing the contingency so that they're over reinforcing, again, those children who are remaining quiet, lying still. The other issue I occasionally see in daycares is that it's kind of a one size fits all. So you've got 4-year-olds on the same nap schedule as maybe an 18-month-old. And again, throughout brain development, you see children as they age, they're able to maintain alertness for longer and longer periods of time. So they'll put a 4-year-old child down for a nap when they simply are not sleepy. And that sets the stage for all kinds of disruptive behavior occasionally.
Brett, on occasion I hear parents talking about other types of sleep disruptions for their children. For example, sometimes parents report their children as being anxious when they get in bed. The child sits there and worries about something. Or every now and then I hear parents talk about, my child has nightmares, or sits in bed and imagines monsters in the closet or something of that nature. Do you have any advice for parents as to how to handle those sorts of problems?
It's interesting. Even though we're in a dedicated sleep clinic, we get most of our really interesting anxiety cases come in through that door. So we have to come up with protocols, specifically graduated exposure protocols, to help children cope with their fears, cope with their anxieties. So, and of course, anytime we're working with children, we have to be working with the parents so that they don't end up reinforcing anxious, avoidant behaviors. One of the first things we check during our clinical interview, and actually with a rating scale, is does this child have experience separating from the parent during the day? Because if you think about what happens at bedtime, if the parent wants to develop a solitary independent sleeper, they put the child in bed and they leave the room. But if that child is never apart or has a learning history of being apart from that parent during the day, we may be better off targeting that skill when it's light out and parents aren't tired and frustrated. So oftentimes we'll facilitate a contingency management program or the excuse me drill by first having parents separate appropriately from their child during the day, and maybe even take walks around the block. So just repeated exposures where the child can experience happy, enjoyable separation from their parent. In terms of nightmares, the first step is to make sure that you're actually dealing with nightmares, because there's a complicated differential diagnosis between sleep tears, which is primarily a physiological event that occurs in the first 3 hours of sleep, and nightmares, which tend to predominate during REM sleep towards the morning hours, the latter half of the sleep cycle, the sleep phase. With young children, oftentimes, first of all, almost all children have nightmares, bad dreams, universal phenomena. But what happens oftentimes is the child wakes up, has a bad dream or a nightmare. They enter the parent's bedroom and they're distressed. Okay, and of course the parents, being well-meaning and being nurturing and caring, say, why don't you just hop in bed with us tonight and we'll help you get through this. Well, it doesn't take toddlers very long to figure out the contingencies there. So and then what you see over time is, rather than waking up towards the latter part of the night distressed, they wake up after they just simply complete their first sleep cycle. They wake up, look around, walk into mom and dad's bed, said, I had a nightmare, hop in bed. And you end up with what is actually a verbal report of a nightmare that serves as their admission ticket. The one thing we can do with children who have, the rare children who have repeated nightmares, is look to see if we can't find themes in the content of those nightmares, okay, or evidence of experiential avoidance during the day that we can use graduated exposure with to help them, again, approach, confront, and master their own fears. So I'll give you an example. I had a young man who was probably 4 years of age who came in after a traumatic dog bite. He got bit right in the face by a German Shepherd. So this was years ago, but we decided to do daytime exposure therapy to treat his nighttime nightmares. Now, first we had to get him out of the parent's bed, okay, the contingency management piece. But second of all, we ended up doing graduate exposure during the day with dogs, because if he saw a dog from 3 blocks away, he immediately ran home. So we didn't start with German Shepherds. Okay, the exposure piece here for young children with anxiety disorders is graduated. We want to make things easier on them initially. So we started with a big old docile fat beagle and had the child learn to pet and play with that beagle, and worked our way up to different breeds of dogs. And the exposure-based intervention did a nice job of actually eventually eliminating those nightmares.
Brett, that sounds like a marvelous treatment protocol for desensitizing people to anxiety-related phenomena. But how about the children that seem to have overactive imaginations, where they get in bed and they imagine all these monsters or goblins or something like that in their room, and they at least report that's getting in the way of their being able to sleep?
Children who especially get into that abstract phase of development where they're thinking a little bit differently than concrete operations tend to allow their imaginations to run wild when they get in bed. Oftentimes parents will tell me that their child's mind races when they enter the bed and they can't shut their mind down. And oftentimes they think that the imagination and the things that they dream up like monsters or ghosts or goblins is causing their issues with sleep initiation. And I would argue that the arrow sometimes can point the other direction. If I place anybody in bed, okay, in a boring environment, when they're physiologically not prepared to sleep, you're not sleepy. Your personality is going to take over. So if you tend to, when given nothing to do, if you tend to be a planner and an organizer or a doer or a goer, you're going to be thinking about those things because there's nothing else, holding your attention. So there are dramatically different opinions among the sleep professionals around the country on how to handle the monster thing. Anything from going in and helping the child, explore the room and show them under the bed and show them in the closet that there's no monsters to, dressing up a spray can and spraying away the monsters. I'm a firm believer in idiographic assessment and treatment. So I want to know, again, what are the antecedents, behaviors, and consequences of these monsters suddenly appearing in the room, oftentimes at nighttime, but never during the day, oftentimes when one parent's managing the bedtime routine, but never the other parents, oftentimes in the home, but never at daycare. So I'm looking to isolate those variables that I can use to design a treatment program. So, and oftentimes, if it has to do with imagination or fears, we'll do exposure-based interventions during the day to allow the kid to develop some coping skills and then simply decrease reinforcement value for those, imaginatory statements at night. I've run into occasional cases where there's a television in the bedroom, and usually when there's a television in the bedroom at bedtime, they don't have the home shopping channel on. Okay, it's usually a show or a video of interest to the child, which again maintains their attention, increases alertness, not only in just the content of the video, but also the light exposure. And again, those children tend to fall asleep later and get less sleep than kids who don't have a television in the bedroom. I'm over the years, I've gone less and less to sudden immediate change, and I've used, just because I think it's more parent-friendly and child-friendly, to fade out problematic sleep cues. So for example, if I've got a child who is watching their favorite video, we'll turn it to a channel that's much less interesting. After a few nights, we may turn it to a non-channel where they only get the white fuzz and replace that white fuzz with nothing but white noise from a fan or a white noise generator. So anything that can be done overnight can be done gradually, and I think parents and children oftentimes are more accepting of those things. Once parents are through the most difficult part of the sleep, multi-component sleep intervention, and they've got the contingency management piece in place, the child is now going to bed cooperatively, they're remaining in their bed, they're well behaved, they are relaxed, they're engaging in sleep compatible behaviors. Some parents still aren't necessarily happy because they may be taking too long to fall asleep. So once you remove those sleep interfering behaviors, you may need to still come back and tweak the sleep-wake schedule to help them fall asleep within 20 or 30 minutes, to be able to reinitiate sleep more quickly when they wake up and complete a sleep cycle at night, or to sleep a little bit longer in the morning.
So if I'm interpreting this correctly, Brett, it sounds like you have several goals. One of them is to help manage some of those sleep incompatible behaviors and replace them with sleep compatible behaviors. And the other goal, which maybe is a result of this, is that then the children will independently initiate sleep within 15 or 20 or 30 minutes of being put in an appropriate sleep environment. And then also to be able to manage some of the naturally occurring nighttime awakenings. Is that correct, Brett?
I think it's just important when clinicians work with parents that they're considering not only behaviors, but also sleep as a behavior. So your child, hopefully is, by the time you're done with the program, well behaved, spending time in bed, calm, relaxed, and able to fall asleep within 20 or 30 minutes. I recently had a case where they brought a young child in, and the physician had suggested a sedative hypnotic to make the child more sleepy. Okay, but during the kind of the functional assessment or the interview, we quickly were able to get parents to identify that once the child left their bed in the middle of the night, as long as they were allowed to enter the parent's bed, the child went right back to sleep. So lack of sleepiness or lack of sleep drive was not the major variable there that we needed to address.
And that case does raise an interesting question for you, Brett. What is your recommendation and position on somnorifics, pharmacological agents that seem to induce sleepiness and drowsiness?
Yeah, given that I've been working in a behaviorally based sleep center for 20 years now, I've come to the conclusion that there are very, very few children who need agents to help them fall asleep. In the large majority of cases, this can be done through behavioral methods. And when I say, for me, behavioral methods is a large umbrella. But it's very rare. I do believe that melatonin can be helpful in certain circumstances with certain populations with some physiological differences. But for the large part, medication really needs to be a last resort, and oftentimes it's reserved for those children who may have a biologically reduced sleep requirements. And you simply need the child to sleep more for the parent's benefit than the child's benefit. So in other cases, if you get a child with biologically reduced sleep need, just again for the parent's benefit, you may need to be able to identify a safe place where you can put that child to entertain themselves so that the parent can get enough sleep.
Brett, since you raised that issue, I'm wondering if you'd also be willing to comment on the side effects of other medications that are not given for the purpose of inducing sleep, but may have some impact on sleep cycles and drowsiness and wakefulness. And the example I'm thinking of are some of the medications that have been traditionally given for ADHD that sometimes have an effect of alerting a person as opposed to letting a person fall asleep naturally.
Yeah, during our interview, we always have a process of identifying what I call daytime factors that can impair sleep at night. And certainly, there are certain classes of medications that can either mask daytime sleepiness, like your psychostimulants, or even impair or interfere with sleep onset at bedtime. So you need to identify those and work with the prescribing physicians a lot of times to combine your behavioral treatment methods with judicious use of medication. Many times I have kids come in who have tried up to 5 or 6 sedative hypnotics, and if they're on an agent when they come in, it's pretty tough to talk parents into eliminating that medication when it's their only crutch at the time. So most of the time we'll ask them to hold that factor stable, to not make any medication changes, as we systematically induce each step of our behavioral treatment protocol and prove to the child and prove to the parents that this child can sleep very well, unremarkably. And at that point, oftentimes it's easier to convince them to wean the child off that medication.
I think it probably goes without saying, Brett, that any change in medication needs to be coordinated with physicians and with their authorization that you're changing medications, quite obviously. But the other side of that coin, Brett, is I'm wondering whether or not physicians are pretty amenable to working with psychologists to do behavioral approaches to sleep promotion.
For the most part, I have had a lot of success working with primary care physicians, developmental pediatricians, pulmonologists, neurologists, I mean, I could go on and on and on. They're in it for the right reason. They want the best for the child. But oftentimes, they simply lack the training and expertise to be able to use non-medication based strategies to help the child sleep. So they're oftentimes very willing and thankful to work with someone who has some expertise in this area to help facilitate a child's sleep pattern.
Well, Brett, we've covered an awful lot of material, and that's been just an absolute fountain of information about behavioral approaches to sleep promotion. I want to thank you very much for participating in this interview.
Hey, I appreciate the opportunity to speak on the issue of behaviorally based sleep problems, and I hope in some way that the information that we presented helps families who have challenging kids with developmental disabilities or genetic and handicapping conditions.
Some parents have difficulty getting their children to go to bed when it comes to be bedtime, and oftentimes they'll engage in all kind of disruptive behavior, making special requests and protesting. And for situations such as that, we recommend a beat the clock routine. And this simply requires the parent to announce that they have a certain amount of time before the lights go out in their bedroom, and that the quicker the child can get themselves ready and in bed, the more time the parent and child will have to do something that's highly enjoyable for the child in the bedroom. So in this scene right here, we have Kyan and Jen Ann, and Kyan is getting ready, close to bed anyhow. So let's turn the scene over, and it's about Kyan's bedtime. So Kyan and Jen Ann.
Okay, Kyan, it's 7:30, so it's time for you to get ready for bed.
But Mom, I don't want to go to bed. Please do not make me go to bed.
Well, I can see that you're upset, and it's kind of been a hard time getting you to go to sleep lately. So I have an idea for a new game.
Okay.
It's called Beat the Clock. So what I'm going to do is I'm going to set a timer here for 15 minutes. And if you can brush your teeth and wash your face and get your clothes set out for school tomorrow really fast, then that'll leave us extra time to read Bath Time for Bunny. But if it takes a long time to get ready for bed, then we won't be able to have a lot of time to read.
Okay.
Are you ready?
Uh-huh.
And marks, get set, go!
Some children show a tendency to get out of bed frequently even after they're placed in bed. For this type of sleep management problem, we recommend what we call a bedtime pass. And a bedtime pass can be anything. In this case, we have just a simple laminated card that says bedtime pass on it. And this bedtime pass, the child is put to bed with a bedtime pass, and this allows the child to get out of bed one and only one time after they've been put to bed. They have to surrender the bedtime pass, and then they get water or attention or whatever for a short period of time with their mother. So here's how the bedtime pass routine works.
Hey, Mom. Can I please have a glass of water?
Yes, but I'll need your bedtime pass.
Okay.
Okay, so you have 3 minutes to get your water, and then you need to get back in bed.
Okay.
Okay, good night.
Good night.
One of the features of the bedtime passes is it's good for one and only one get out of bed episode. If the child comes out a second, third, or fourth time, the parent is instructed to, with minimal interaction, send or walk the child back to bed. This is not a time for reinforcing interaction between the parent and child. It's simply a direction or maybe even a prompt to go straight back to bed. You'll see it in this particular scene here with Kyan and Jen Ann.
Okay. Mommy, I still can't sleep.
I know, Kyan, but you've already used your bedtime pass, so...
Oh please, can I stay up with you?
No, I'm sorry. It's time for you to go to bed. You need to go back to
Okay.
bed right away.
Another feature of the bedtime pass is that many parents build in a reward system. More specifically, if the child has made it through the entire night without cashing in their bedtime pass, they can oftentimes bring the bedtime pass out in the morning and, so to speak, cash it in or trade it in for some sort of special reward. Sometimes the reward is a material thing, a favorite toy. Sometimes it can be something as simple as some special time with mom or dad to play a game or something of that nature. So here's the way that sort of interaction would typically go in the morning after a successful night.
Good morning, Kyan.
Oh, good morning, Mommy. Look what I still got.
Oh, you made it all night without using your bedtime pass.
Yeah.
What should we do for your special treat?
I want pancakes for breakfast.
That sounds good. You want to help me make them?
Yeah.
Let's go. Come on.
Many parents have different goals for their sleep routine for their child. Some parents are perfectly fine with co-sleeping or the child sleeping in the same bed with the parents. However, many parents are especially interested in teaching their child to be an independent sleeper, that is, sleeping independently in their own bed for the entire night. One of the challenges many people face is separating from their child after a little bit of bedtime. And in this particular drill right here, it's referred to as the excuse me drill. Jen Ann will illustrate how to tactfully say excuse me while she's spending some quality time with Kyan in bed, leave, and then come back, and assuming Kyan is behaving well, to re-engage in some reinforcing activities with Kyan. Then she will systematically increase the length of time that she excuses herself from Kyan. So here's an example. This is, once again, Jen Ann and Kyan.
Then she ran fresh water and whiskers and said, "Oh, you smell so clean and nice."
Yes, that's good. All right. You wait here with the book and baby Lovey Bear. I'm going to go
Okay.
check on Flopsy the dog, okay?
Okay.
Okay. Wow, I like the way you're reading so nicely and all snuggled up
Thanks.
here in bed. Oh. Okay, let's see.
And little bunny kissed his mommy and hugged her.
Tight.
They're now
All
all
done.
done.
Sighed Mrs. Rabbit.
It's time for bed. Where are my other little bunnies?
Yeah, we're almost done. Okay, I need you to stay here one more time. I'm going to go check on our soup, and
Okay.
then I'll be back to
Okay.
check you in.
Okay. She found them in the kitchen. Oh no, what a mess. Kidder, Mrs. Rabbit, your titter added, you all need another bath. Yes. Little bunny all except me.
Kyan, you have done really well in here by yourself. I'm
I
so
read
proud
the
of
whole
you.
book.
Good. Would you like me to maybe rub your back for a little while before bed?
Uh-huh.
Okay.
I think that would be
Okay, here's your bear. There we go.
Ow. This doesn't feel like a videotape. It feels like a spa.
Yeah, time for bed. Okay, good night.
Good night.
I love you.
Some children have difficulty once they get in bed settling down, and they get worried or anxious, and they sometimes are disruptive and call out for their mother or father. And under those circumstances, we will recommend that the mother or father or whoever the caretaker is tell the child from afar without going in the room, calm down, and then I'll come in and check on you. And then once the child is calmed down, then the parent comes in and checks to make sure the child is okay, has minimal interaction, and then leaves once they've reassured the child that everything is okay. So in this scene, Kyan is in bed. He's been in bed for a while. He's having difficulty sleeping, and Jen Ann will come in and check on him only after he calms down and quits making quite a ruckus.
Hey, Mama. I really need to. Can you please come in and give me some company, please? I'm really scared. Can you come
I
in?
need you to quiet down.
Okay.
Once I hear that you're quiet, I'll come in and check on you.
Okay.
Okay, it's time for bed. I can see that everything's fine. Okay. Here, let me help you get tucked in. Here we are. Sweet dreams. I love you.